Hey, it's Matthew Holt, THCB, catching up with old bud Aneesh Chopra. Aneesh, of course, formerly Secretary of Technology of Virginia, CTO of the United States under some guy called Barack Obama, who seems like a very long, you look the same, but it seems like a very long time ago that guy was running the show. Aneesh, you are still straddling that sort of private sector public divide, and we're going to talk first off about a new challenge launching here at JPM, which is around cancer navigation. So tell us about the challenge. What do you got to do with it? Who's running it? And what's it all about?
Well, first of all, Matthew, thank you for this. You are the heart and soul of Challenges Past.
I certainly was around about that. Indu Subaya. You may remember that Indu Subaya woman was somewhat involved in the whole Health 2.0 challenges.
I do.
We have Sarah at Luminary Labs and a bunch of others doing the same thing. But challenges are still around, yes.
In 2016, President Biden issued a call to action when he was vice president on the way out of the Obama at Datapalooza.
Yeah.
And he said, I want cancer data sharing. Fast forward to a year ago, December, the Biden administration convened the CEOs or the leadership teams at Epic, Cerner, Meditech, McKesson, Flatiron, and a few other related parties like CVS and others, and said, look, what can we do voluntarily to drive adoption of cancer data sharing? And at the time, CMS launched the Enhancing Oncology model, where they mandated a dozen or more clinical data elements be shared from practices to CMS who participated. And those data elements were normal tumor stage, cancer stage, and related things, which are not today in the formal structured medical record.
Right.
And so in the past, this was done by Excel spreadsheets in hand.
Yep.
And so CMS said, can we move forward with an idea to do it more? And thankfully, by September of last year, Epic and Ontada, McKesson's division, successfully demonstrated at Datapalooza that they were in fact capable of doing this. ONC announced just a few weeks ago that the first batch of reportable quality measures came in, and sure enough, McKesson in particular, who will be talking today, announced that they were able to successfully move towards a FHIR-based approach to reduce administrative burden. And that's an important aspect, because you need to increase the supply of cancer data sharing, but then you want to use it. And if a person's newly diagnosed with cancer, you know that there's going to be a complexity to their life. Forget the anxiety around the condition. Scheduling appointments with radiology and medical oncology, and considering and consulting with lab studies and others, it requires coordination and navigation. So the Biden administration created a new billing program, a reimbursement program called Principal Illness Navigation, where practices can add this sort of peer support navigation. So the theory behind the AI challenge is, could we democratize access to navigation services through AI by taking advantage of all the interoperability and what's needed to understand the patient's challenges, to put them together to get them to the absolute best possible treatment plan. And that is the heart and soul of the challenge. And I'm grateful the Robert Wood Johnson Foundation has contributed funding, Academy Health is managing, and organizations like the American Cancer Society, Cancer X, and others have voluntarily agreed to drive participation. And I'm hopeful app developers will see these new APIs, understand what's needed to democratize, put the two together, and make this available to every patient whose family member is struggling with this challenging condition.
Yeah, I mean, clearly there's been a lot of back and forth, and Mickey Tripathi has published elsewhere about getting access to a whole, and Don Rocker and others have been involved, who may or may not be back, you never know, have been talking about, how do you get access not just to the sort of mandated FHIR part, but all the other stuff like scheduling and a bunch of other things that are important, right? So that's an ongoing piece, and there's always sort of back and forth between the owners of, not owners, owner is the wrong word, the controllers of that data, who are health systems and providers and what have you, and the people who want it, who are, potentially can release it to other providers, but also our patients and consumers and consumer representatives and health plans and God knows whom else. So, the idea should be right that much more data is better, and we can do things to ease the burden, because the burden, as you've talked many times, it's both incredibly administrative. It's obviously clinical, right? You're a patient, life sucks because you have cancer, but that's clinical and obviously financial as well. And the more we can do about that, the better. And I think that kind of stuff has been part of the reason that the reaction to the assassination of the UHC CEO has been so extreme, right? Because people know this stuff is out there and isn't going well. And so, something that's great. Tell, on the practicalities of the challenge, where do people go? What do they do? Who are you looking to take part?
Yeah, so there's 3 participants that we're looking for. We're looking for cancer centers that want to be test beds to welcome the app developers in to participate. We're looking for data contributors, so the EHR companies that are opening up these APIs, like Ontada will be announcing today, to make that information accessible to app developers. And then obviously we're looking for app developers who are putting all these pieces together, understand the requirements of cancer navigation, which the American Cancer Society manages, and help build applications that can support patients that need these navigation services using AI tools. So that's the goal. The website is on herox.com. And it is a longer tail than that, but it's the transforming
I'll
cancer
drop a link
navigation.
into the challenge here. The good news, the surprising news, given that how long ago it was that Health 2.0 was working on these challenges, which is now 15 years ago, with the folks with you and the folks in Toll Park and others at back in the Datapalooza early days, was that I was just involved in a challenge running data for the state of Hawaii, where Jack Lewin is putting an all claims paid database. And there's an AI group called Lab AI. It's an international challenge, and they managed to get on a data set that Millman put together out of Hawaii data. They had, I believe, 52 teams that ended up build something over a weekend. So there are people still out there saying, yeah, I can take health. And some interesting stuff was built. Now, of course, a lot of that interesting stuff that gets built looks something like stuff that's already on the market that somehow hasn't got adopted. But, hey, there is a kind of, hey, what you can do is we think, those of us who've been around long enough, we're always going, oh, no, this looks great, but doesn't it look like that thing that didn't quite make it in 2018 or whatever? But anyway, it's good. All right, brilliant. So let's hope that challenge goes well. Is that... I don't know, Jason's around, so there's money involved from the prize.
About a $50,000 prize.
Yeah, but better than a big poke in the eye. So that's great. All right, real quick. So that's the challenge. We'll talk more about that. I will come back to you later. I know you're doing a bunch of other work on Medicare Advantage and data and stuff like that. But just on your business personally, you were the president of Care Journey, and now Care Journey is part of Arcadia. What the hell did Care Journey do, and what the hell does Arcadia do, and what happened other than, you're not quite sitting on the beach, but I see things were good. But tell me, give me both sides of that equation.
Arcadia
and what happened.
Care Journey have been partners in the market for more than 5 years.
Okay.
If you're taking on financial risk, you need a data platform that will organize the patient's longitudinal record. And you need a perspective on what's happening in the market around you to understand who are the best doctors to bring into your network or specialists to refer to be preferred providers within the network. So you need an inside out and an outside in view. And while we were doing these things together, we felt there was an opportunity to go much faster by coming together. And so we've merged the two businesses. It's been 2 peas in a pod. The families love each other, and together we are helping build capability that will move the value-based care industry much further and much faster towards that real-time, always-on understandability of what that patient's condition is and what it is that we can do to make a difference in their lives. We're power users of these emerging FHIR APIs. CMS introduced a daily FHIR API of claims data to replace the monthly CCLFs. We're one of the fastest growing users of that data to help our ACOs, who are getting much more timely notification in claims, that which they can manage clinically. We're also working with all the EHR companies to use their FHIR native capabilities so that the sourcing of the data from the EHR networks into the longitudinal record is much faster and much more cost effective. So that's been wonderful. And still spend a good chunk of my time in strategy, accelerating the public-private standards and roadmaps, standardization of social needs data, veteran information, making sure that we have payers and providers that can share data with each other with a lot more turnkey, standards-based approaches. And most, as we saw with this cancer challenge, very specific specialty areas that need help. My view is if we can do more public-private collaboration, data platforms who are anchored on doing right by longitudinal needs of the patient are going to do very well. And I'm grateful to be a part of the Arcadia family more formally.
So am I right in saying Arcadia was mostly helping support sort of care management or health plans?
That, helping the care management infrastructure, mostly on the provider side.
Oh, more on the provider side, okay.
But there are definitely health systems and health plans who've built similar capabilities, and so there's provider enablement for health plans that Arcadia has supported, and of course provider ACO networks. Right. And the legacy Care Journey business has been serving all stakeholders.
Okay, and that's mostly bringing in the data and the sort of what's going on. So let's talk about that very final mile, right? In terms of integrating it back into I am a doctor with a patient sitting in front of me. what do I get told to do that's different, and why is this going to make life better for me and for my patient?
Arcadia launched a Smart on Fire app called Inform. We make that natively available in EHRs that are Cures Act compliant, and it's a flip of the switch to get that infrastructure turned on, and it allows the ACO networks to determine what content coming out of their data warehouse do they want to present in what form or fashion. And so that's a customization that we work with our members to say, do you want to provide historical understanding of the patient condition? Do you want to put together care gap recommendations, areas where we may not be the primary reason for the visit today, but are relevant to that patient's success over their chronic health condition? And we put all of that in a manner that is built on the very regulated rails that we've meant for this system to work. So to the doctor, it's loading an app like they would an app store into their EHR. And my hope is that more and more EHR systems support what is already required in the Cures Act, and we're going to be right there, power using those capabilities.
Poking the people perhaps who may not be as far advanced as they should be. Do you have an example of a clinical specialty, a system, whatever, where this is started off, and what's the difference that you're making?
Yeah, look, I think to be very pragmatic, in day one of value-based care, you want to make sure you have a full understanding of the patient's health history. And so understanding not just what was required to document what happened in the fee-for-service encounter, but to really understand this person's got a chronic condition, it's making progress. That documentation is not what's typically collected in traditional fee-for-service medicine. So the first round of this use is to make sure that we've got awareness of and full completion of an understanding of the patient's health status. Then there are all these existing gaps. This person does or does not have a series of outstanding needs in order to meet evidence-based quality care. So those are the two areas you're going to see the greatest impact. Improvements in the underlying documentation accuracy of the patient's health status, and a reduction in the number of outstanding care gaps. A diabetic that gets a test on a frequent basis, or on occasion an eye exam, and to make sure that those are done in a timely manner adherent to evidence-based medicine.
All right, last question, and I don't want a long soliloquy about this because I know this could be a 45-minute answer if I let you go. All that stuff you're saying, there's a lot of discussion about this weird stuff called AI you may have heard of that apparently is going to help by reading notes and doing a lot of stuff and answering these questions and all the rest of it. A lot has changed in the last 18 months and a couple of years. And
one of the most exciting times to be a technologist in the healthcare sector.
Isn't that what you say every year? All right, I'm giving you a hard time, but where do you think we are so far with that? And I'm starting to see a little bit of a backlash. People say, there's too much hallucination. Study about AI scribing out of, I think it was Atrium Advocates, saying it didn't actually improve doctors' productivity. Where do you think we are in this sort of whole hype cycle adoption of that? And do you think it's making...
Well,
how big a difference is it making?
I think the nouns and the verbs. On the noun side, the ambient dictation is clearly a high value. Whether you measure it on productivity gains or you measure it on cost savings, probably the most appropriate metric is burden reduction.
Yeah.
And so in reality, people are voting with their feet. And so we're just seeing people have joy back in their lives, and there's a price to be paid for that. I'm spending my time thinking about the verb. How do we apply this analytic horsepower to mine longitudinal data sets to identify what are disease patterns that might recommend treatments that people may not be traditionally understood, or ways in which we can better navigate. And that area is just scratching the surface. So I am hopeful we're going to see more responsible uses of AI to understand what evidence-based medicine looks like in real time. So if there's a change in protocol, whether you're prior authed to deal with it, or you want to do better medicine internally because of an internal quality program, you shouldn't worry about what hat you're wearing. There should just be honest answers to what is the best protocol for someone who's dealing with obesity, and when's the right time to do behavioral coaching, and when is the right time to begin bariatric surgery or GLPs. These are the questions that matter to the American people, and AI is going to help us learn what works and what doesn't faster.
All right, fantastic. I didn't expect pessimism from you about that or anything else. I've been talking with Aneesh Chopra, these days head of strategy at Arcadia, formerly way back when CTO of the US. Aneesh, thanks for your time.
Thank you.